What we're going to talk about first is pharmacokinetics. This is what happens from the time the drug hits the body till it's gone. All right. So let's get back to pharmacokinetics. This is, again, what happens from the time the drug hits the body till both the drug and its metabolites leave the body. So in order to understand that, we need to talk about first, how do we get the drug into us? Well, there's this thing called absorption. And absorption is what has to happen in order for the drug to be into the bloodstream. So if you think about that, at first, using IV preparations that go directly into the bloodstream means that there really is no absorption, right? So we can bypass the absorption idea by just giving the drug IV. There's other ways to absorb drugs, though, and you can think of some. If we had a live class, we would talk about this, but those things include what? So transdermal. So if you have a patch of some drug, it can go through the skin and get absorbed right into the bloodstream. This is a picture of somebody getting sublingual nitroglycerin spray. That's another way. It goes right into the bloodstream because it's absorbed through the sublingual space. There's oral medicines, right? So you could take the pill, it goes into your stomach, it gets absorbed into the bloodstream through usually the duodenum. And those are the ways that we have to get drugs absorbed into the body. All right. I don't think I'm missing any, but transdermal, sublingual, oral, those are the big ones. Okay. And then there's distribution. One of my favorite questions from a patient one time was, so I take this pill, this cholesterol pill, and it goes into my body, but how does it know where to go? I just thought that was kind of an interesting question. I had never thought of it that way before. Well, that's distribution, right? How does that pill know where to go? Well, you and I understand that the pill goes into the body through the stomach. It gets broken down into, the tablet gets dissolved, and then it gets absorbed. Each molecule gets absorbed into the bloodstream, and it just goes all through the body. There's no way to direct it to a certain site in most cases. So that distribution is getting the drug to where it needs to be. When I looked up drug distribution on the web, it returned this picture, which is, according to the people who published this picture, the world's first drone delivery of marijuana. And that's not really what I was going for, but it's essentially the same concept, right? We have the drug, in this case it's marijuana, and we want to get it to where it needs to go, which is the person who paid money for it, right? That's essentially what distribution is. Now there's metabolism. Metabolism is how the drug gets transformed in the body. Now sometimes when we take a drug, like let's say, I'm going to use beta blockers a lot this semester. In fact, I'm going to use beta blockers so much that if you fall asleep in the middle of class and you come to noticing that I'm looking at you and everybody else is looking at you too, and you have no idea what we're talking about, just mutter something about beta blockers. You'll probably be right. Okay. So think about beta blockers. When you take a beta blocker, which slows down the heart rate, among other things, lowers the blood pressure, things like that. It does that in its active state. The drug metoprolol is the active drug, and that's what takes its effect on you. But there are other drugs where we absorb them into the body. We either inject them IV or they go into the lungs. That's another one. I didn't think about that. But you can inhale drugs and it gets through the lungs into the bloodstream, gets absorbed that way. But here's one that's called aminophylline. Aminophylline has no specific action on the body. It's what we call a prodrug. A prodrug gets absorbed into the body and then it gets converted into something else. So in this case, we put aminophylline into the body as a prodrug. It then gets converted into a metabolite, and it's just caffeine. This is how we can administer caffeine, because caffeine by itself is not an injectable drug. It's not something that we can regulate in the body very well and dose correctly. So we go the backdoor method, and we use aminophylline, which we know and we can predict how much of it gets converted to caffeine, and that's the active metabolite. Okay, so some drugs get metabolized and disappear, right? The liver does a lot of that. Some drugs get metabolized into their active component, and that's a good thing. So know that metabolism just means how the drug is transformed, either into an inactive component or the prodrug gets transformed into its active metabolite. In this case, aminophylline gets converted to caffeine. Okay? Then there's excretion. How do the drug and the metabolite get eliminated from the body? Here's a picture of garlic, right? We all know what garlic is. And if you were friends with Chris Long and went to the same Eagles game that I went to with him 30 years ago, well, 25, you would have remembered vividly that Chris had several servings of, and by servings I mean entire bowls of garlic that was roasted, and he ate all that stuff with some delicious bread right before the game. And I had to sit next to this guy, and the smell was horrific. Now, what was it that I was smelling? What I was smelling was the metabolite of garlic that he was breathing out. That's how the body gets rid of garlic, right? Some of it gets out through the stool, some of it may get out through the urine, but a large part of it, an offensively large part of it, gets breathed out through the lungs. Alcohol is the same way, right? Alcohol gets metabolized by the liver, and that active metabolite gets dispelled or excreted through the lungs, and that's why the breathalyzer works. It's not actually measuring alcohol, it's measuring the metabolite of alcohol. But that's the excretion of the drug that we're interested in, okay? So how does the drug and the metabolite get eliminated from the body? Now, there's something that we need to talk about, and this is what was covered in that little video that you guys did. And that is the concepts of onset, peak, and duration of a drug. So, when we administer a drug, let's say that this is the de novo dose, right? The initial dose hasn't been given before, so the blood level of the drug is 0 at the beginning. Then the drug gets administered, and it gets absorbed, and during this absorption, the blood level gets up to a certain, what we call minimal effective concentration. All right, once it reaches that minimal effective concentration, that's where the action of the drug begins to take effect. Okay? No action of the drug happens down here. If we talk about a beta blocker, we give metoprolol, there has to be a certain amount of it being absorbed before it gets to a part where it's going to lower the blood pressure and lower the heart rate. So initially it gets absorbed, nothing happens because we're still at this low concentration. And then the heart rate goes from 70 to 69, all right? And then it goes to 65, and it goes to 60, and finally at the peak level, it's at 58, all right? I'm making all this up, but that's the idea. The peak level is where you have, theoretically, the greatest concentration of the drug and, well, it's definitely the greatest concentration of the drug, but theoretically, you have the peak effect of the drug at this peak level, right? Because it's the highest blood concentration. So it stands to reason that you should have the peak effect of the drug at the peak level. Then the body distributes it throughout the throughout itself, and it gets distributed to places that don't have beta receptors, if we're talking about beta blockers. And so that same amount of drug is being eliminated, and the distribution means that since it's going to places that don't have beta receptors, there are less molecules that are available to hit those beta receptors. And so this decreasing availability because of distribution happens. Simultaneously, there's elimination of the drug. And those two things together, the distribution and the elimination, mean that that drug level continues to fall until finally it gets to this minimal effective concentration and surpasses it. So now we don't have any effect of the drug because it's all gone. And those things happen during these three phases. One is the onset of action, so the time from dosing until it hits the minimum effective concentration. That's the onset of action. How long does that take? Most PO drugs, most but not all PO drugs, take 30 minutes or so. And that makes sense. You take the pill, and that pill gets absorbed into your bloodstream and it gets distributed to the body. And during that time, the action of the drug does not take effect, right? And that onset of action takes 30 minutes or so. Then the period of time that occurs from the beginning of the onset of action until the end of the onset of action, or the end of action, or the termination of action occurs. That's called the duration of action. All right. So in this drug's case, it takes 2 hours for absorption, or 2 time units, whatever those time units are. And it lasts from that time for 8 hours later, which brings us to 10 hours. So this has a duration of action of 8 hours, right? 10 minus 2 is 8. And then the termination, where there's still some drug floating around, but it's not effective. It's not at an effective concentration. All right? The things I didn't mention here are the toxic level and the therapeutic drug range. So the therapeutic drug range is everything from the minimal effective concentration until you get toxic side effects of the drug. That therapeutic range, or that therapeutic index, is something that we're going to be revisiting quite a bit this semester, because a lot of what we do depends on that therapeutic index. When we talk about drugs like DIG, we're going to talk about therapeutic index because it has a very narrow therapeutic index. You give a little bit of the drug, it doesn't do anything because it's down here. You give a little bit more, and now you have good effect. You give a little bit more, and now you're at the toxic level. So that narrow therapeutic margin, or that narrow therapeutic index, means that you have to give just the right amount. There's some drugs like, let me see, Keppra. Keppra is an anti-seizure medicine that, unlike all the other anti-seizure medicines, it has a very wide therapeutic index. So you can give a little bit, it works. You give moderate dose, it works. You give a huge dose, it still works, and the patient's not toxic. That's very useful, right? That's a very useful thing, because now I don't have to get blood levels. Now I can just know that when I give this drug, it's going to work because it has a wide therapeutic window. It's safe to use at a variety of doses. DIG, on the other hand, comes in 0.125 or 0.25 milligram pills. Those are your choices. And if you have kidney problems, you're going to use 0.125 maybe every other day, or maybe twice a week with dialysis or whatever. So that has a very narrow therapeutic window, 0.125 milligrams every day. A drug like Keppra, has 800,000, 1,200 milligrams dosage range because it has a wider therapeutic window. All right. Next, we'll talk about half-life. Learn this definition. The half-life of a drug is the time required for half of the drug to be eliminated from the body. Okay? The half-life is the time required for half of the drug to be removed from the body. So if I give 500 milligrams of a drug and it has a 1 hour half-life, how much drug will I have left at 1 hour after the initial dose? Well, it's going to be half of that, right? Because it has a 1 hour half-life. So the 1 hour period of time, I'm going to go from 500 milligrams to 250 milligrams still in the body. How about an hour after that? At 2 hours, that's an hour after the first half-life. At 2 hours, I've had one half-life, bringing me down to 250 milligrams. And at that second hour, I've had another 125 milligrams, right? Another half of what's left in the body takes me down to 125 milligrams. Does that make sense? So the half-life is the time required for half the drug to be removed from the body. There are different kinds of half-lives. There's the elimination half-life. How long does it take for half of that drug to leave the body? There's the plasma half-life. How long does it stick around in the plasma? Drugs like amiodarone get stuck in the tissue. They get dissolved into the tissue in the blood. Their elimination half-life is months, right? It may be 9 months because this stuff sticks around forever, gets absorbed into the fat, and it sticks around forever. But the plasma half-life, when it actually is in the bloodstream, is very short, maybe only 60 minutes or 90 minutes or something like that. And then there's the therapeutic half-life. Well, if all this drug is getting absorbed into the body and it's getting stuck to the fat tissue, what does that mean? It means that that drug's not available and circulating in the blood, and it's not available to the tissue to do its action. That's the therapeutic half-life. How long after we give a drug does half of its therapeutic effect disappear? Okay, so the half-life is the time that it takes for half of whatever we're talking about to happen. Elimination half-life is how long does it take for half of that drug to be eliminated from the body. The plasma half-life is how long does it take for half of that drug to leave the plasma in the body. And it may go somewhere else. It may, it may be eliminated. It may be absorbed into other tissue in the body. The liver may soak it up, or, it may go into the muscle or what have you. And then there's the therapeutic half-life. How long after you give that dose is it before half of the therapeutic effect is gone? We use that when we talk about things like sedatives or anesthetics, right? If I'm going under general anesthesia, I want that anesthetist to know what the therapeutic half-life of propofol is, right? Because I don't want to wake up in the middle of that operation or whatever procedure I'm having done. So let's look at it this way. This is so important for you to understand that we're going to spend a little time talking about it now. We're going to spend a little time later in the semester talking about it. We're going to spend time more in the semester talking about it. And by the end of the semester, this is going to be ingrained in your brain because it's so important. When I first graduated from college, I worked at NIH. One of the things that we did at NIH was electrophysiology studies on patients with terrible arrhythmias. And so we would bring them into the hospital and we'd put them onto an antiarrhythmic drug, and we'd have to wait until that drug was at steady state. We're going to talk about steady state in a minute. And then we would take them to the EP lab and make sure that we couldn't induce an arrhythmia, and then we were very happy. The other thing that we did was we brought patients into the hospital and we stopped their antiarrhythmic drug. And we had to wait a period of time until they got out of steady state, and they eliminated almost 100% of the drug from their body. Okay? So when we give a drug, remember this is a de novo dose. They haven't gotten any of the drug yet. So we're going to start at 0. And then we give the first dose of drug and it goes up and it follows that pattern, right? This is absorption, and then we get to peak level, and then we have elimination and distribution that get rid of it. And now, once we start on this downward path, we're going to give the next dose. This is the next dosing interval. So now we get up, 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 and the absorption happens and we get to peak level, and now we start to eliminate it and it gets distributed throughout the body. And now at the end of that dosing interval, we're going to give our third dose. And look what happens. As we do that, the mean concentration is increasing. After we get to 4 or 5 half-lives, we now are at steady state. And what does steady state mean? Memorize this. Steady state means that when I give the next dose of medicine, it's not going to change the plasma level very much. It's not going to change the steady state concentration when I give that next dose. And similarly, if I'm a little late giving the dose, it doesn't really change the steady state concentration. And that's why the steady state is so important. Because if you've been on a drug for years, or weeks, or months, or whatever, you've been on a drug for a long period of time, you're at steady state. And so when I give the next dose of medicine, is it going to affect anything? If I'm giving a beta blocker and I'm already at steady state, am I going to see the heart rate plummet when I give that next dose? No, because I'm at steady state. And when I give the next dose, it doesn't appreciably change the concentration. And if I'm late giving the dose, it doesn't appreciably change the concentration because we're at steady state.